It's Dr. Tofai. Welcome to Hernia Talk Live, our weekly Q&A. My name is Dr. Shirin Tofai. I am your hernia and laparoscopic surgery specialist. Thanks to everyone who's joining us live on Facebook as well as on YouTube. Also on Zoom. And later on, you can watch this on YouTube. And thanks for also joining me in the conversations on Twitter and Instagram at Hernia Doc. So I'd like to introduce you our guest for today. His name is Dr. Salvatore Docimo. We call him Sal. He is a bariatric surgery specialist, but he also treats a lot of hernias. He is based in Tampa, Florida at the University of South Florida, and I'm super excited. We were like talking behind the scenes so much, we had to stop it to start our Hernia Talk Live because we were having so much fun just talking back and forth. So we're going to continue the conversation with you all. So as always, feel free to submit your questions. We have about a dozen questions already submitted beforehand, which we'll try and go through. But welcome, Sal. Thank you so much for joining me. I appreciate it.
My pleasure. Thank you for the invite, and very excited to be here. Excited.
Thanks.
Yeah.
So Dr. Docimo is very well known in our field. He is technically trained in not only minimally invasive surgery, which includes hernias, but also bariatric surgery, which involves weight loss surgery. So that's why the topic for today's session is obesity and hernia repair, because it's, as you know, if you've followed Hernia Talk before or done any reading, you know that obesity is one of the main risk factors for incisional hernias and for, actually, is it a risk factor for regular hernias or just incisional hernias?
I would say obesity
different studies show different thing. Everything.
Obesity is a risk factor for all types of hernias.
Yeah.
It's kind of a global, obesity is a global disease, and the reality is that any part of your abdominal wall where any hernia that can occur can really, obesity can have a negative effect on it, whether it's incisional, even inguinal, even hiatal hernias.
Hiatal hernia, yeah, that's another one.
Yeah. So I think as we dive deeper into the data, obesity is a global disease that affects every part of your body, every system, negatively.
So what is the definition of obesity? Let's start with that.
So the easiest way that most people have used or define obesity is really looking at your body mass index. So what is that? That's really just a ratio between your height and your weight. And the reason why we had to kind of create this ratio is if we think of, a great example I always give, because everyone knows who he is, but if you look at like Shaquille O'Neal, right, the famous basketball player,
yeah,
he weighs over 350 pounds. So if I told you that, I have a patient 350 pounds, everyone would kind of scoff, right? But the reality is because he has such a significant height, he's over 7 feet tall.
Yeah.
When you look at his BMI, especially during his playing days, it was actually pretty low. It was actually below 30. So that's why we had to create this index to get a better idea of what obesity is. So BMI is, again, the ratio between your height and your weight. And the reality, and again, there's a huge spectrum of obesity. So when we start getting to a BMI of like 35s and 40s, when we start entering into the phases of morbid obesity, as bariatric surgeons, our biggest cutoff is 40, because anybody who has a BMI of 40 or more is going to be a candidate for surgery of some type of bariatric surgery, regardless of what their comorbidity is.
So that's about 60, 70, 80 pounds overweight.
Over their ideal weight. Exactly.
Yeah.
And then when you start getting down to a BMI of like 35 to 40 is when we start looking for comorbidities, hypertension, diabetes, obstructive sleep apnea, et cetera. So this is kind of our significant, our cutoffs that we currently use. And what's really interesting topic, even more so, is that now in the world, we know that obesity is a much larger problem than what we currently are using. And ASMBS, which is one of our national organizations for weight, is actually looking to lower the indications for surgery even lower, going toward a BMI of 30 or higher, because we know that it's such a significant problem that it doesn't make much sense for us to wait until the problem gets out of hand before we start helping patients. So
true.
So
this literature supports the cutoff being 40, which means really after 40, it's best not to do elective hernia repairs. But you really don't want to do it on a BMI of 39 either, right?
Mm-hmm. Yeah. So if it, and what it's kind of blurring a little bit nowadays. What does that mean? Some of the research I published on previously, we actually looked at component separation in open surgery. So
Mhm.
that means like making a really big incision, and where we're doing really complex hernia repairs, component separation repairs. And we actually found that when individuals and patients hit a BMI of 35,
Yeah,
that was our cutoff, because when the patient's BMI got 35 or higher, they were at a much higher risk of getting surgical site infections, which is a really an indication that you're
major
probably going to
problem.
get a hernia back,
Yeah,
right?
yeah,
So for open repairs, it was even lower, and our
yeah.
data was even validated by another additional study that came out, I think a year or two later, an even larger study. So 35 in open hernia repairs is probably what's been kind of hovering around there for quite some time now.
Okay, yeah, I think 30, yeah, so 34,
Yeah,
35, 36, in that
exactly.
range, it's,
Mhm.
we as surgeons feel a bit more comfortable operating, and
Right.
especially some people carry it not necessarily in their belly a lot, so it's more
Mhm.
representative of a safer population. So the first question actually submitted is, what is the optimal BMI for a non-emergent ventral hernia repair? So really 35 or below.
Yep.
If you want to have a good outcome, no infections, and well, lower risk of infections and lower risk of wound problems, and a good secure repair, like under 35 would be much better than 35 to 40.
Agreed. Yeah, I agree
Yeah.
100%. And it's kind of interesting because, people was like, well, why? Like, what's the problem with obesity anyway, right?
Yeah.
Um, so the problem is, like you mentioned, that anytime you have such a large, people who are in general, people have higher BMIs start to get a larger abdominal wall, or they get a larger pannus. So that pannus is
True.
primarily composed of what? Fat tissue. It goes from the ab wall, then you have the subcutaneous tissue, our belly, and then our skin. So when we make these large incisions through the tissue, and we try to get down to the musculature, which is where we do our hernia repair, the
Yeah.
problem then arises with two main things, right? Because there's such a huge distance between the muscle and then the skin, you have all that fat tissue, which doesn't really have good blood supply. When we try to close these areas, they don't heal very well. They're prone to infection. And again, even when you get an infection, antibiotics don't really work that well, because it's hard to get from that blood supply to the skin where the infection
Right.
is.
Right. So much
So
tissue in between.
yeah. So that's why all this kind of makes sense to us from an anatomy type of perspective and how we think about it.
The next question is, if a person has a hernia repair and then loses weight after the repair, will that help the outcome as well?
I tell my patients, any type of weight loss that they get, will have a benefit. So if you have, it depends on how high your BMI is, but the more weight that you lose, even right after a hernia repair, the better your outcome, because the long-term effects of that, again, you're going to have less tension on your abdominal wall. In terms of surgical site infections, I
Mhm.
think it probably doesn't matter. And the reason why is because the reality is, to go from like a BMI of 40 to 35 in such a short period of time after surgery,
Yeah.
it's really not possible. You're talking about like 20, 30, 40, 50 pounds. So
Yeah.
the reality is you should if you're going to go for a surgery, in that media postoperative period, you want to already have your BMI really low, or below
Yeah.
35, I would say. Yeah.
And I would say most of the like of the real failures occur early after surgery.
Yes,
They don't
exactly.
occur, 2 or 3 years later.
Yeah.
So the highest rate of recurrence occur early. So that's when you really want to be optimal
Yeah.
with
That's
your weight
exactly.
loss.
Yeah, that's the whole reason that we always say we want to optimize the patient as best as possible before they
Yeah.
even get to their hernia repair, which includes obviously weight loss.
And then the question that was submitted before is, okay, now that I've lost the weight, how long do I have to keep it off after surgery?
The doctor answer to that is forever,
Always.
right?
Yeah.
Always, always. I mean, that's the true and the correct answer.
Yeah.
Because obviously you're going to lose all this weight. We want to get you optimized. And then when you go for surgery, and as you just mentioned, in the immediate postoperative periods where some of those hernia occurrences do occur. Okay.
Yeah.
The problem is, if you start to gain a significant amount of weight after your surgery, even if you have a small recurrence, we know that as patients start to gain weight, that actually can propagate that little recurrence to grow and grow and grow over time. So it actually even
Yeah.
puts you at a higher risk of getting, that little recurrence increasing over time as well. So kind of
And every
interesting.
time you recur, you're losing tissue in the process. So it's going to be an even bigger hole. usually
Exactly.
than the
Yeah.
original. Yeah.
Yep. And how does all that work? Is because we know that, as time goes on and people start to gain more weight, it actually puts a significant strain and tension on that abdominal core area, the
Yeah.
abdominal wall. So there's issues there. So yeah.
And the other, this is a good live question. How do you adjust BMI for one's frame, like large, medium, big boned, muscular people,
Yeah.
and then male versus female? Do you just eyeball them? I mean, is it like an eyeball thing?
No, no. So
Okay.
it's kind of that's a great question. Great
Yeah.
question. And the answer to that is we don't. We really can't account for frame. People are always like, well, I'm kind of big bone and stuff like that. We don't. We unfortunately
I
don't have
think I'm big boned. I attest to that
No.
always.
So we can't accommodate for it at the moment. So the honest answer to that is BMI is our current indicator that most of us that we use. Is it the best one? No. For those reasons you just mentioned, it's hard to accommodate for where the weight is dispersed, where it is, if people have larger frames or not, things like that. It doesn't really take into account. What's even more interesting is that, we're kind of rethinking what is the best indicator for obesity. And what we're kind of looking at is we're looking at other things like CAT scans, something called visceral adiposity. Visceral
Yeah.
adiposity is just a kind of clever term for basically the fat around your organs. And what we're starting to see is that visceral adiposity is probably down the line going to become a much better indicator of true obesity than what we're currently using, which is BMI. So kind
But
of interesting.
do you refer to that as in terms of obesity, the disease, or obesity, the girth, which you have to fight to be able to fix the hernia? Do you know what I mean?
Yeah, I mean, I think it goes hand in hand, right?
Okay.
Because it's kind of interesting as well, because when we look at, some people have done lab studies looking at adipose cells, and they've actually demonstrated in the lab, so like bench work, things like that people are doing in a lab, but they've actually found that obesity and adipose cells actually cause a significant amount of inflammation.
Mm,
So inflammation, especially when you're talking about wound healing, like when you're putting an abdominal
yes.
wall back together. So if you have a big hernia and you're putting all the tissue back together, the last thing you really want is to have a significant inflammatory process going on, because you're not going to get the proper healing that you're looking for, which is probably going to weaken your repair.
Right.
So when we talk about things like, fat around the abdomen, when we talk about actually fat inside the belly around the organs, this all has a significant negative effect because it does create this pro-inflammatory environment, which trying to allow something to heal.
Yeah.
Obviously, when you want wound healing, there's always some level of inflammation with wound healing, but you don't want it so out of control that it actually prohibits wound healing from happening.
Hmm.
So it's actually really kind of fascinating, like what happens with that. People think, well, I'm just heavy and, et cetera, but there's actually a microbiological thing going on with these fat cells. So that's why we're saying that even BMI, which is not a good indicator of BMI of fat, when you look at visceral adiposity, that may be a better indicator, because it's a better indicator of more of like that pro-inflammatory state, which
Yeah.
again won't let your hernia heal very well. So
Okay. So
really
this
interesting.
is the next live question is kind of in that same
Mhm.
realm. So there are two ways fat is distributed: pear versus apple shape, right? So
Uh-huh.
pear is where you kind of mostly in the hip, upper body
Yep.
is smaller. And then the apple shape is where you're kind of centrally obese
Mhm.
around the belly. Some people with metabolic syndrome have more intraperitoneal and visceral fat than subcutaneous fat. So fat around your intestines, as opposed to like how many inches you can
Yep.
pinch.
Exactly.
What are the different surgical problems and complications between patients with the pear versus the apple? Like the amount of you carry in your belly versus the amount you carry in your skin.
Fantastic question.
Yeah.
The answer to that is I don't think anybody really knows the definitive answer to that.
Okay.
So I think again, when we talk about doing bariatric surgery, and the reason why is again, is we don't have a really good, there's no study saying, hey, does patient with pear shape versus the other types of shapes of body, body shapes, does that have negative impacts? The reality is that when we do all these studies, the best indicator that we have right now is body mass index, right? So we
Mhm.
just can only go on BMI when we try to figure out what are the complications. My personal experience is it doesn't really matter in all honesty. I'll give you an honest reason why is because as we've moved on in terms of perfecting our surgical technique, whether it's laparoscopic or even robotic,
Yeah.
once we get it once we get into the abdomen, for the most part, certainly when we're doing like robotic weight loss surgery, that body habitus doesn't really affect our outcomes in terms of our surgery, or how easy it is for us to do. So the other things that normally come into play, like wound healing, the comorbidities of the patient, all the stuff that can affect like the healing of staple lines when we do a sleeve
Yeah.
bypass, all that is really, it's kind of irrelevant in terms of what your body shape is, as far as we know. As far as we
know.
yeah.
I mean, back in the day, like when I was a medical student, they were saying that, it's better to be pear than apple shaped because from a cardiovascular standpoint, less people
Yep.
have heart attacks or cancers even. I think heart attacks was the thing. If they don't have central obesity. There's some
Yes.
people that are super thin, like legs are thin, arms are thin, and then they got huge kind of midsection.
Yeah.
And that seems to be more of a cardiovascular risk factor than
Yep.
people with the same BMI that carry it in their hips.
Yeah, well, that kind of goes back to what we're talking about, right?
Yeah.
That central obesity, again, when we look a little bit further in detail, is probably where when people have central obesity, I think they're more likely to have like that higher level of visceral adiposity. And that's where all that comes in with like how can we better measure obesity? Getting a CAT scan and measuring the volume of fat around an organ is probably going to be a much better indicator of comorbidities than something just as kind of generalized as a body mass index. And this is why we're all trying to work on trying to find a better indicator, because we know BMI is not the best. It's not the best way to measure obesity. So we're trying to find other ways of doing it. But that's true. Yeah. Central obesity just goes back to what we were just talking about, that visceral adiposity, the fat that's actually within your abdomen, around your organs, is a lot more detrimental than somebody who has less visceral adiposity.
I think with the new AI, all this kind of artificial intelligence, they're probably going to be able to take a picture of you and say, like, based on your configuration, they'll give you more input than the BMI. Don't you think? I feel like we're going to be heading toward that way.
Definitely. I mean, that's kind of these are the things that we're working on actually with exactly with the radiology, right? So when we have CAT scans of patients, we can just if we take the same cross section for every patient, we can actually put it in a computer system now, and it'll actually let us know what is the true volume of fat in that patient's abdomen compared to the other pictures of all the patients. So it's happening. I mean, it's happening. And
That's
I think,
cool.
yeah, I agree. I think, surgery has gone through so many evolutions, right? We went from open surgery to laparoscopic, which we're probably going through now. You can even say robotic, and the next stage of revolution is going to be, artificial intelligence.
Yeah.
Kind of cool.
Very cool. Okay, keeping on the same topic, does having a large amount of intraperitoneal fat versus subcutaneous fat complicate laparoscopic access, either TEP or TAP? How's that for a question from an audience?
That's a great question. That's kind of a double-edged sword. And what do I mean by that?
Yeah.
We always talk about, especially when we're doing like a TAP repair, like a preperitoneal, when we try to get to that preperitoneal plane.
Yeah.
Surgeons like when they see, oh, there's actually a nice little fat plane here, right? When you can get to
it's a
that plane of
buffer.
fat, it's a buffer. It's a buffer for, you don't shred the peritoneum, things like that. So I think for the most part, it's kind of a balancing act. But the reality is, in my opinion, is the best optimization is to get you to lose as much weight as you can. Does it make the surgery a little bit more difficult? It's hard to quantify. But from my perspective, I don't think it matters in the long term, right? So it doesn't matter. I mean, I think the once we optimize them, once we get their weight down as low as possible, I think, for me, I can do the surgery whether the BMI is 30, 32, 33. So I haven't, that this is all kind of just like hearsay and like our own, it's like dogma, but quantifiable answer to that. It's a great question. I mean, it's a fascinating question.
So in general, laparoscopic or robotic is favored over open for patients that are obese, right? Less wounds, less to heal externally, less infection rates. Do you find that robotic is superior to lap for the morbidly obese, or vice versa?
So let's talk, we'll separate that into two questions, right?
Yeah.
Two parts.
Okay.
First part, bariatric surgery. And again, this is my opinion. I know I'll probably anger some people by saying this, but in my opinion, I would never want to go back and do laparoscopic weight loss surgery ever again.
Oh, really?
So my entire practice from a bariatric perspective is all robotic.
Wow.
I haven't
Okay.
done, I really haven't
I
done
have
a lap.
questions about that.
Yeah, I haven't done a lap robotic bariatrics procedure in probably almost going on, well over a year now. So
Okay.
I've completely converted to all robotic. And I'll tell you why, because once you get your ports into the abdominal, once you get your ports in position,
Yeah.
the robot, it's irrelevant in terms of how thick the abdominal wall is, what the strain is on the robot. The robot is what gives you the benefit to be extremely precise. And let's be honest, right? Like we are human beings. Like as the day goes on, when you're working against a BMI of 50, 60,
So
and by
hard
the
on
time
your
you get to
body.
that, right, by the time you get to the end of your day, you are physically exhausted.
Yeah.
So
Shoulder, neck, horrible. Back.
exactly,
Yeah.
right? So, when you talk about the robot, once the ports are in position, it's almost irrelevant what the BMI is in terms of me doing my work. The only negative drawback is it goes into the fact that as the BMI in some patients, as your BMI goes up, the visceral adiposity increases, which makes things a
Mhm.
little bit more difficult. But at the end of the day, I told you I would never go back and do a lap weight
You
loss.
were never trained during the open bariatric surgery, I assume.
No.
I was.
Yeah, exactly. Yeah.
That was really bad on your body because
I can imagine.
not
Yeah.
only did you have to be able to reach the wound, which
Mhm.
is much further away from you than normal,
Yeah.
but they didn't have the beds that they have now.
Yep.
So we operated on a normal patient bed, which is like twice or three times wider than a typical bed for the operating room. So you're even further away. And I'm telling you, as a resident, and we were such high volume for these open surgeries, I finally told my attending, I'm like, we're just doing a lot of work and it's really hard on our body. He's like, well, I appreciate you. I said, could you appreciate us some more? He's like, how can I help? I said, maybe a massage certificate or something.
Yeah.
And I was joking, but I wasn't joking. And he actually gave us massage certificates because it was so hard on our body. So
Even
hard.
even though I could just imagine retracting. I mean, it probably took a couple hours to do the case, right? So if you can
Oh,
imagine
yeah.
just pulling,
We
pulling
had
on
a
the abdominal
system.
wall, that's right. I mean, it's
Yeah,
just
we
pretty.
had a system.
Yeah.
Yeah, but it was very hard on our body. Okay, so I'm going to push back on you a little bit. So
Yeah.
the issue I have with robotics is the robot is very strong,
Mhm.
very strong.
Yes.
And some surgeons move those arms much more violently than others.
Yes.
When you're doing an operation on a bariatric patient, I 100% agree. Like on the surgeon's body, it's so much easier because you don't feel it anymore. You're just on the robot. But I feel that maybe the risk is when you're the surgeon doing it laparoscopically, two things. One is you can move the instruments to be in line with how you need to operate as opposed to perpendicular.
Mhm.
And that's less torque on the abdominal wall.
Yep.
You can also use smaller instruments if you wish to, not necessarily 8 mm. But if you do it robotically, the way the trocars are placed and the amount of torque the robot is placing on the patient's abdominal wall, I feel is a lot of injury. No?
I think you're definitely correct. So why do we know this, right? How do we know this to be fact? Because what we saw initially, especially in robotic surgery, I'll give you an example. We use these different size robotic ports. So you have like, most commonly nowadays we use like an 8 mm robotic
Yeah.
port, and then you use like a 12 mm robotic port, right? So what we see is that an 8 mm robotic port, you have to be careful. Exactly what you said. Like when you put these ports in, on the robot, when you're working on it, I really you can't feel the tension. You can't feel how much torque is on the ab wall.
Yeah.
At the end of the case, you have to be really diligent to go back and actually look at the ports, because as time throughout the case, as this port is moving up and down, left and right, and you are
Pulling
torquing,
on the tissue. Yeah.
pulling on it, you are causing local damage there. And sometimes that 8 mm port can increase in size to like a 12 mm port, which can put you at risk for additional hernias.
Yeah.
So this is very true. So,
Has that been shown? to have
In a
more
study?
port site hernias?
Yeah, I don't know. I'm
I
not
don't
that
know
I'm
that it's been
aware of. I mean,
shown.
that could be
Yeah, not that
interesting,
I'm aware of.
interesting study that we could do though,
Has it been
right?
shown to
Yeah.
have more pain
No, I
for
don't
the
think that's
patient?
changed. As
No.
far as I know, no. I mean, we
Okay.
all pretty much, but I'll give you an example. Like I said, I always look at the ports at the end of the case. I will kind of gauge them. I personally close all my 12 mm robotic ports. I'll put a suture through it. I will close that port. I'm obviously a little bit more paranoid probably than most about hernias, so I close all of them.
We
The
we we like paranoid surgeon.
Exactly, that's what we like, right?
Right.
So, and the fact that I do hernia, I'm kind of aware of it.
Yes.
So
Yes, that's true.
8 mm robotic ports, you have to look at the port. You have to understand, what it looks like before and after. So if I see that the 8 mm robotic port is increased in size, I will also close that. And,
Hmm.
I've unfortunately, like we've seen that, like we've seen some patients come in with port site hernias and, they're always like, oh, well, I was using an 8 mm port. I don't understand. You're not supposed to get hernias, but the reality is probably throughout the case, it increased in size and
Yeah.
what a hernia.
So this is pre-robotic, but we looked at all of our patients who had port site hernias after bariatric surgery. And one really interesting thing we found was if they presented to the ER
Mhm.
within 21 days of the surgery, it was always an incarcerated or strangulated hernia. Whereas after 21 days, it was just like, yeah, I have a hernia, but it
Yeah.
wasn't an emergency. So
Oh, I
they occur
believe you.
early. Yeah,
Yeah,
21
definitely,
days.
definitely.
Okay, this question is about tissue repair. So what is the optimal BMI for hernia surgery? We kind of discussed that.
Mhm.
And what is the maximum BMI you should have if you want to maximize the changes of the, maximize the opportunity of getting a tissue-based repair?
Excellent question. So those are a couple of things on that. So probably the most common and probably the most utilized tissue repair. Now, again, tissue repair is a very small percentage of my own practice, but
Yeah,
tissue
but
repair, probably
umbilical hernias, right?
yeah, yeah. Umbilical hernias, and then even when you talk about inguinal hernias, right? So
Yeah.
inguinal hernia is probably the most common one that's performed nowadays, is probably a Scholdice repair.
Hmm.
And again, it's a tissue-based repair. You have overlapping tissue, overlapping suture lines. So a Scholdice repair has been probably one of the most studied by a center literally called the Scholdice Clinic.
Clinic.
That's where it
Mhm.
originated from. Okay.
Yeah.
So they have excellent outcomes, very good outcomes. They do a great job. This is all they do at their hospital. But they are very particular in terms of who they choose to undergo the
Yes,
surgery. What
correct.
does that mean? That means
They
that
refuse to operate on anyone that's obese.
exactly right. So now their BMI cutoff, I'm not intimately aware with it, but I can tell you it's well under 30,
Yeah,
most likely, just
yeah,
from I can see the
it
patients who've
is.
had the repair. So
Yeah,
when you're talking about tissue-based repairs, you have to have a BMI that's significantly low, probably well below 30 in order to have a positive outcome.
yeah,
So anybody who comes in my clinic who said, or, and they say, hey, listen, I have an inguinal hernia repair. I want to get it repaired. I don't want mesh. I want a tissue repair. They have to have a BMI that's, below 30. They have to be pretty skinny to get that. Because the
agreed.
reality is I can probably do a tissue repair in a higher BMI, but it's going to fail.
Yeah,
And
and then you're stuck with even worse problem.
exactly. So
Yeah,
so we do know that. And anybody with a higher BMI, let's say if they have a BMI of 33 and they have an inguinal hernia, they're going to get a mesh repair all day long. Like I won't
yeah,
do a tissue repair because I don't think it's the right thing to do. And again, the Scholdice Clinic, who are the world experts in this tissue-based repair, they know that and they understand, and that's why they're very particular in who they operate, which is always a low BMI. So
yeah.
that's the
What
easy
is
answer.
the maximum BMI you consider safe for performing hernia surgery? Well, that's a hard question.
It's a hard question, and why is it? Because there's so many variables that go
What
into
if
it,
you have
right?
a BMI of 60 and they're there with like incarcerated hernia or strangulated hernia?
You have to, in those situations so let's say a patient has a BMI of, 55 or 60, and they come through the emergency room and they have, significant incarceration, obstructions, or even strangulation where the bowel is dying.
Yeah,
In those situations, as a surgeon, you got to do your best, right? You have to go in there, you have to fix the bowel injuries. In terms of the hernia in that specific situation, what I would probably do is just, you want to live and to fight and you want to live another day, right? You want to fight another day. So what do? You kind of, there's a couple options you could do. You could just do a tissue repair. Maybe you can put some type of prophylactic mesh in, something absorbable maybe in nature, but you don't want to burn any bridges. Like I would
correct.
never do a formal repair on a BMI in that situation, like a component. I just would never do that, right? We know you're probably gonna have a complication. So you just temporize as best as possible and you let the patient know you're probably gonna get a hernia in the next 6 months to a year. And then hopefully in the meantime, you're gonna optimize them, get them to lose weight, and then eventually bring them back and do a formal repair. Now,
So
if
BMI 50 or 60, let's say you save their life, right? You do
Yes.
a life-saving operation. You deal
Mhm.
with the bowel incarceration or strangulation, but you don't give them a perfect hernia repair because it's going to fail 100%, pretty much, right?
Exactly.
So, or like 99%, basically almost every situation, if you do a good repair, it's going to fail.
Yeah.
So then do you talk to them about weight loss surgery?
Yeah. I mean,
Okay.
exactly. So in my specific practice, so my training, I got additional training in weight loss surgery as well as complex hernia repair. What does that mean? Probably like component separation, those sorts of things. So in our practice, someone comes in with a much higher BMI. I'll give you an example. Same thing we use like that. I'll give you an example of a BMI 50. So if they
So
come in,
that's like a 400-pound patient?
it depends on what their height is. So a BMI 50, yeah, like 400, maybe 5'10",
Okay.
5'6", something like that.
Yeah.
Um, so if they come in with that BMI with a large ventral hernia, again, we know that any type of repair, you're probably gonna have an issue. So we have to move them toward some type of weight loss solution. In my particular practice, that means weight loss surgery. So I talked to them about the risks and benefits of weight loss surgery, and then we enroll them in our program, which on average is somewhere between 4 and 6 months. We get them squared away for their weight loss, their bariatric surgery. Once they get their bariatric surgery, then we have to wait somewhere between 6 months and a year for them to lose weight to meet their goals and for their
Yeah.
weight to stabilize. Then we actually start talking about doing a complex hernia repair. So it's a staged approach.
Yeah.
And I would say probably 100% of these situations, the weight loss surgery that we're going to do on them is going to be what's called a sleeve gastrectomy.
Mm-hmm.
We don't want to do a bypass in those patients because the way that we reorganize the bowel in a bypass, they
Mm-hmm.
still have this hernia, which if the bowel incarcerates or strangulates, now you got a massive
Okay.
problem. You have a
Okay.
life-threatening
Sure.
problem. So, yeah.
So I've had patients that come to me and they say, they've had, let's say, 1 or 2 or 3 failures. And part of the failure is because they're morbidly obese
Mhm.
and no one's really addressed that part of it. And maybe some of them were emergency surgeries, right? So they really didn't have a choice. And I say, okay, well, we're going to stage this. I say, be patient with me. We'll
Mhm.
get you there, but you're going to need multiple surgeries. One's going to be a weight loss surgery. One's going to be the hernia repair, blah, blah. And some of them tell me, oh, I've had so much surgery. I can't imagine having another surgery.
Yeah. Yeah.
How do you explain that to a patient that they need the weight loss surgery?
So you have to just, you have to just be honest with them. I think that's
Yeah.
the most important thing. You're just honest with the patient. You say, hey, listen, obesity, also along with this hernia, this is a life-threatening situation. All
Hmm.
right. So I think you explained in like, let's say the patient is having chest pain, they get a cath, right? The cardiologist takes some pictures of your vessels and they find that they have blocked arteries.
Right.
I would say probably the majority of people would say, okay, I want you to fix my blocked arteries because that can probably kill me. I want to bypass or stents or whatever it may be. We have to basically talk to them on the same level with obesity and these hernia repairs, right? So,
Yes.
because the reality is this is probably in the same level in terms of how dangerous this is walking around with a significant hernia where they already had complications and a large, in an abdomen that is, completely kind of distorted, and they have also all this obesity. So we have to talk to them on the same level and say, listen, we can't go in and do your hernia repair because if you have a major complication, along with the fact that you're obese, you're probably going to have we're talking about significant morbidity and even a mortality, a
And
death.
anesthesia is not even safe
Yeah.
each time when you're
No,
morbidly obese.
no, exactly. So we explain to them, say, listen, this weight loss surgery, it's not, it's not aesthetic, it's not a
Not
plastic surgery.
cosmetic. Yeah.
It's a life-saving procedure. We have to get you to the point where you are healthy again to get a surgery safely. So that's the reality. I mean, that's the honest truth, what we're
And a
trying to do.
lot of patients are like, no, I can do it.
Yeah.
I'll do it medically, but to lose, let's say 100 or more pounds medically, it's going to take years.
Years.
Whereas with
Yep.
surgery, it'll take within 1 year, maybe.
Yeah. There's really three main options for these patients. So one, obviously we kind of touched upon, which was weight loss surgery.
Yeah.
The other option is going to be a really, really strict diet. Like there's some, published publication, I think from, I want to kind of top of my brain here, but I think Cleveland Clinic published some material on
Mhm.
very strict liquid protein diets for like a couple of months, where they just try to get their BMI down, So you're basically talking about almost like a semi-starvation, a super calorie restricted diet. That's another option. And then your third option is going to be weight loss medications. Weight loss medications. Normally for me, I will refer these patients to a medical doctor
Yeah.
who
That specializes. Yeah.
specialize in it, because every day there's so many medications out there right now.
It's the
Um,
fad now.
it
I mean, I
is,
don't know about Florida,
yeah, it's
but
all,
everyone in
yeah,
LA, it seems, is on a medication, weight loss medication, Wegovy, Ozempic, Mounjaro. Everyone, all of a sudden, you're like, you saw him last week, you saw him this week, you're like, are you taking that medication?
I know,
It's
exactly.
pretty crazy.
It's crazy. And so I think for that reason, if you're going to be on these medications, especially, you have to work closely with with a medical doctor. So for us, luckily, we have a medical doctor who's in our practice, our
Uh-huh.
bariatric practice, who I can refer directly to, and I can tell them, hey, listen, they don't want to do surgery, they're refusing surgery, which is okay. I can't force anything on anybody, but I still want to help them as best as possible. So I'll put in my notes, I'll say, hey, listen, I need them to get to this BMI goal, do your best, see if you can get them down there. If you can't, send them back, and then we'll have another conversation. But the problem with, their medications, they are meds, so they can have, negative interaction. They give contraindications or other cross contamination with other medications that you're taking. So that's
If
why for
you
me,
if you were a BMI of 60,
yes.
would you do the medication or would you do surgery?
Oh, I would recommend surgery all day long.
And if you were a BMI of 40, would you do surgery or do medication?
That's a tough question.
Yeah.
I'm a hammer, and the patient, a obese patient is a nail. I'm being honest. So I'm a surgeon, so I'm gonna operate, right?
Yeah.
But the reality, let's talk. We can answer this question probably in a little bit more evidence based. So if we do the surgery, the long term weight loss is probably better with the weight loss surgery.
With the surgery, yes.
For the medication, and I'm probably will anger some people saying this, but the reality is, with a medication, when you stop the medication, there's always a high risk of gaining all that weight back and maybe
Yeah.
some more. Okay.
Within the first year, right? That's what I
Right.
read. Yeah.
Exactly. So I think that's the conversation I have with patients when they say, well, can I just try the meds? It's like, you can always try them, but the reality is, for me as a physician, I think it's better if you can lose the weight and keep it off as long as possible with bariatric surgery. That is probably the way to go, because do you really want to be on a weight loss medication indefinitely for the rest of your life?
Plus, if you have a hernia and that's why you need to lose the weight, could you imagine if you lose the weight medically, then you have a beautiful abdominal wall repair, then you gain the weight, then someone starts talking about surgery, but then they have to go through your mesh or something? That would be horrible.
Oh, definitely, definitely. So, so this is the conversation I have with them.
Okay.
So, but if they totally refuse surgery, which again is I can only advise them as best as possible.
Yeah.
But if they totally refuse surgery, I recommend them either to a strict diet along with some type of weight loss medications.
Okay. How do you supplement the BMI value to keep into account for other factors? Oh, we kind of discussed this, I guess. Let's go to the next question. Is surgery the only way to repair hernias, or can it be fixed via diet or exercise?
So good question. The easy answer to that is no. I tell patients when they have a hernia, one of two things is going to happen with the hernia. One, either it's going to stay exactly the same, which is kind of unlikely, or two, it's going to get bigger.
Yeah.
So that's the easy answer to that. Yeah.
It's like a sweater. It'll either not lose shape or it'll lose shape, but it'll never get smaller. Like a knit sweater,
I know exactly what you mean. Yeah.
Yeah.
Exactly. So yeah, unfortunately, hernias are, you gotta fix them for the most part.
I will say though, there are some patients that are very symptomatic because they just have been told, don't exercise, don't lift any weights,
Mm,
etc. And so they've actually lost their tone and they've gained weight, and now they're more symptomatic from their hernias, whether it's umbilical or
yep,
inguinal. And sometimes I say, you know what, go back, become more fit, etc. And then their symptoms are not as much, or they go away. So
definitely.
the hernia is still there. It doesn't cure anything. But in terms of symptoms, sometimes being more fit may improve their symptoms.
Absolutely. I mean, I always tell, I tell patients this, when they come in and they've lost, let's say, we see them a couple weeks after surgery and they come in and they've
Mhm.
already lost like 20, 25 pounds. And they're kind of like,
That's
oh,
great.
I, but they're always like, oh, I want to lose more. Oh, I wish I had
Yes,
lost more already. I'm like, listen, I'm like, it takes almost up to
hard.
a year to lose, to kind of level out where you're going to be. But I always tell them this, I was like, go and find 25, something that weighs 25 pounds, hold it in your arms and walk around for like 20 minutes to 30
That's a
minutes
good one.
and just feel how like you can't even do that for 5 minutes, right?
Good one.
Think about
Yeah.
how exhausting that is. That's what you were physically carrying on your back, on your knees, your hips, everywhere. And when they put that in perspective,
Yeah.
then they get it. Cause I'm like, think of a bag of flour is like 5 pounds. Imagine carrying 5 of those around,
Yeah.
so
Do
kind of
you
physical.
as a bariatric surgeon feel like you can never be obese? Like there's like a stigma that as the surgeon you could never be overweight.
Oh my
Is
gosh,
that a thing on your shoulder?
I'm
Is
sure
that
there's a huge,
stress?
I'm sure a huge amount of my surgeon friends are going to start texting me and making fun of me. I'm like, I'm so paranoid about I'm always paranoid about my weight.
I
Always.
mean, right?
It's the most self-conscious thing ever.
Like
Yeah.
being like a hairstylist and having the worst hair,
Exactly. Exactly.
right?
No, you can never, I don't know, you can never really be in, I guess you could always be in better shape. Everyone could always be in better shape. So,
Okay.
but
All right,
yes,
here's a
it is
pa-
it
here's
is
a
the most self-conscious field besides probably being a plastic surgeon, right?
yeah, exactly. Like, can you imagine being a plastic surgeon with like a really huge crooked nose? I don't know. Or lots of wrinkles on your face.
I see this question. This is a good one.
Yeah,
We're gonna
so how much weight should I lose before surgery? I'm 260 pounds and 5'2". I did the math for you.
Oh,
It's
you did
47.5 kilograms per meter squared with an
perfect.
abdominal hernia.
So let's say, okay, if we're gonna do a open hernia repair and you have a big ventral hernia, it's gonna be open. The
Yeah.
answer to that is you want to get down to a BMI of 35 or less. And the patient, so I know what the next question is gonna be. Well, how many pounds is that? So let's say I have a calculator up here right now. So if
Okay.
we put 200 pounds, 5'2", that's going to bring you to a BMI. I'm a little off, so 36.6. So let's say 175 pounds.
Yeah.
That's too low. So let's do 190. 34.7. So you would have at a height of 5'2", using a BMI calculator, which anyone can Google, there's 100 of them online.
Yeah.
At 5'2", you'd have to get your weight down to 190 pounds, which is going to bring you to a BMI of 35. So luckily I can do this math.
That's 90
So
pounds.
yeah, so that's a good amount of
No,
weight, right?
that's 70 pounds
70 pounds. So you'd have to lose 70 pounds in order to become a candidate for an open hernia repair
and keep it. And you have to keep it.
and keep that off. Yeah.
Yeah. So 70 pounds may be reasonable for some people. Do you recommend them to be in a medically overseen weight loss program, or do you send them to Noom or Weight
I would still
Watchers
I would still recommend bariatric surgery for this patient
surgery? Okay, for
because
70
they're
pounds,
gonna,
we do bariatrics.
yeah, I mean, again, they're gonna have more long-term weight loss over time.
Mm-hmm.
If they have any other issues like diabetes, hypertension, they're gonna have a great resolution with it as well.
Okay.
And like you said, I can almost control I can control the whole narrative behind the whole thing. What does that mean? That means that I can say, hey, listen, I'm gonna enroll you in the program today. In about 6 months, you're gonna get weight loss surgery. And
Yeah.
about 6 to 12 months after that, you're gonna have a complex formal hernia repair. Okay. So I can kind
Okay.
of give them a time frame. I can control the narrative. Whereas if I
That's
just say,
true.
hey, listen, go to a medical doctor, take some weight loss meds, come back to me whenever you lose this amount of weight. That could, that could happen in 3, 4 months, probably not. Or they can just be lost to follow up indefinitely and nothing ever happens. Then they end up having a major issue down the line. So
I feel it's like planning a vacation, like
yeah,
you find the date, you get the hotel, the reservation, all that. But if you're just like, maybe summer we'll do something, that's the more the medical way.
exactly, exactly. So I think from that perspective, if you are a candidate for bariatric surgery, you should probably get weight loss surgery, and it's going to be the best solution for you in the
Okay.
long, especially with the
Yeah.
hernia.
Yeah, with a BMI of 47.5, that's automatic candidate, right?
Exactly.
Pretty
Yep.
much.
Mhm.
How and why does obesity affect your chances of getting a hernia or recurrence? Is it always only a mechanical problem? That's a good question.
Great question. It's a combination of everything, right?
Mhm.
So, it's a combination, as we talked about, the stress on the abdominal wall, like the physiologic stress of that large pannus pulling on the abdominal
The
musculature.
skin, even the skin,
Yep,
right? Yeah,
exactly. The skin, the inflammatory process of having the significant amount of adipose tissue, that obviously comes into play. The high risk of infections. We know that in a wound that gets an infection after hernia repair, that's almost like your risk of it recurring is dramatically high.
yes, yeah,
So all of these come into play. And then other things that we talked about, right? Like even if you get a small little localized wound infection that could normally be treated with antibiotics, in an obese patient, those antibiotics can't penetrate to the skin area. It's really hard to
right.
treat. And then the
So
worst case,
primarily it's mechanical and also gravity.
yeah,
And then the rest is like infection, diabetes, poor healing.
all these things, all
Aren't
those,
obese patients already malnutrition by definition?
yes,
So that
they are.
affects healing too, right?
Yep. So there, all these other markers for nutrition like albumin, prealbumin, all these labs that we get in all these obese patients are all
Yeah,
majority of them, they're kind of out of whack.
yeah,
So it's a
yeah.
complex, obesity is a disease. And it's a disease in the fact that it affects so many organ systems negatively. Again, there's issues with mental issue, central nervous system, muscle
Cancer,
skeletal,
right? Doesn't it affect cancer?
cancer. Yeah, I mean, we published data looking on the cancer rates after bariatric surgery, and even cancer rates are reduced after you lose weight, which is kind of fascinating,
Wow,
right?
that's a
So,
big deal.
cancers like colorectal cancer, I believe, breast CA as well, are really
Breast, yeah.
directly affected with this. So, yeah, so it's a bad disease, and we're fighting it more than ever, unfortunately.
Wow.
Yeah.
All right, let's see. How would you rate obesity among other risk factors like chronic cough, constipation, or smoking in terms of causing a hernia or its recurrence?
Those are all they're all bad
Pretty
things, right?
bad.
So, yeah. So, uh,
Would you
chronic
rather have a morbidly obese patient or someone who coughs, is constipated, or smokes? I would rather have the coughing, constipated smoker,
probably,
right?
or I can at least say I rather have the obese patient because I can at least help them, right? So,
Oh, that's true.
yeah. But all these, probably obesity is up there. It probably is number one, right?
Yeah,
So,
I would say
and
number
the
one.
and I think the reason why is like a chronic cough. There's probably some underlying issue there we have to be able to fix and figure out. Like most people shouldn't have a chronic cough, so we have to figure that out.
Yeah,
Constipation, I can probably fix with some routine, medications, some type of stool softener, well hydrated, change your diet a little bit. That's kind of easy. Smoking, you just gotta say, listen, if I'm gonna be doing a complex hernia repair, I gotta get you to quit smoking. So that's like either you quit or you don't. It's kind of
yeah.
a easier conversation. So I think overall, probably BMI is probably number one for those reasons.
Why do bariatric patients have a higher rate of infection and poor wound healing?
So I think all the reasons that we talked about before,
So
again,
diabetes and
yeah,
malnutrition
everything, right? So diabetes,
and poor
malnutrition,
blood flow.
poor blood flow, all the physiologic reasons, anatomical reasons. Like I said, it's so hard. Like adipose tissue, in order for the blood flow to get to the skin is just so decreased, right? So
Hmm.
all these reasons come into play.
Yeah. How has bariatric surgery changed recently, and what are currently the surgical options to treat obesity, and when do you recommend them before, at the same time, or after hernia? Do you ever recommend it during?
That's a tough question to answer. The answer to that is probably overall no. And
Yeah.
actually, let me rephrase that. We're actually kind of revising or currently working on a newer study that we're going to hopefully publish here in a little bit of time. But um, when we looked at some of the data, because so what they're asking is like, let's say someone has a hernia and they go for weight loss surgery, should you fix the
Yeah.
hernia at the same time along when you're doing bariatric surgery? The
Hmm.
easy answer to that is what we're finding now and the most recent stuff that we're working on is
Mhm.
if you need to put a mesh in, so if you're doing a weight loss surgery and you have a hernia that will require some type of mesh, the answer to that question is no, you shouldn't fix the hernia. That's
Okay.
why before we were always like, it's all or, it's like, yes, you should fix it. No, you should fix it. I think this probably gives a little bit better guidance. So if you get in and you have a hernia that is going to need in an ideal world, if you were going in just to fix a hernia and you need a mesh, the answer is no, don't fix it during the time of weight loss surgery. And a couple reasons, because again, if the mesh, there's a higher rate of infection when you put the mesh in an obese patient. When we're doing weight loss surgery, we are cutting bowel, especially in a bypass,
Right.
we're cutting the bowel. There's always a chance of contamination of the mesh, etc. So some people, what they do is if they have a very small, let's say belly button hernia, what they'll do is they'll reduce the hernia, maybe put a couple of stitches in there, but they won't put a
Mhm.
mesh. So I think that's probably where now the guidance is going, is that if you need a mesh at the time of that surgery, just don't fix the hernia.
So one thing was surgically, if you go in to do obesity surgery and you notice there's a hernia and there's maybe some little piece of fat stuck in it from the omentum, you're supposed to leave that, right? You're not
I
supposed
leave,
to,
I
you're
leave
supposed to
it.
leave it. Yeah.
The
And then, but
Yeah.
if it's, let's say, the belly button and it's just a punched out hole, um,
Mhm.
you do put a stitcher in there? Wouldn't that potentially tear and make it a bigger hole?
I'm gonna give
Or
my honest answer. What I
judgment
do,
call?
I
Yeah.
I try to not touch any of this stuff.
Yeah, don't touch anything.
I leave it
Agreed.
as is, because my mindset is whatever I do at that moment in time is not going to be the best solution for the patient, right?
Yeah, I
So
agree.
if I'm in there doing weight loss surgery, I'm going to tell them, hey, listen, I saw the X, Y, and Z. After you lose your surgery, we're going to take you back and fix it.
Yeah.
The a great, what you mentioned before was like, that fat that's stuck in this little hernia, it's almost like a cork. And even if the fat gets strangulated at some point or likely it's not going to be a life-threatening thing. But if I pull the fat out and then a piece of bowel pops in there and gets
Mhm.
strangulated, now we're talking about a significant problem. So
Yeah.
I try to avoid touching anything of the abdominal wall at the time of a weight loss surgery. I want to fix it once they lose weight and give them the
And
best
is
out.
there a risk of a bowel obstruction early after surgery from the rapid weight loss falling into the hernia?
There's some data that suggests that. So I think that kind of that's where that option of just like leaving fat in there and like not touching the hernia, because hopefully
Yeah,
it's going to act as like a blockage or a cork for bowel getting
yeah.
in there. There is some data to suggest that, yeah.
Here's a great live question. I've always wondered this too. So we know that sleep apnea is a risk factor for
Yes.
hernias. Is it because sleep apnea is related to obesity, or obesity leads to a hernia, or is it a oxygenation thing at the tissue level? Like, do we know why sleep apnea is associated?
Interesting question. It's like a chicken or the egg type of question,
Yes.
right? So um there's a different components. Like there are individuals who are quote unquote, thin, skinny, whatever word you want to use, non-obese, who have sleep apnea, and
True.
it's a genetic problem.
Okay.
Right. But we do know that as when people gain weight, majority of people don't just gain it in one little area. They do gain it throughout their whole body. And also that also affects
Right.
what's called like your oral pharynx, or the back of your throat and your mouth. So when I go and before I do weight loss surgery, I go in and do what's called a screening endoscopy, do an upper endoscopy, make sure, the stomach is okay. When I put the scope in, I mean, it's pretty dramatic, the amount of tissue that's in the back of the throat. I mean, it's hard to even get into the esophagus, the swallow tube. So as you gain weight, that's where all that obstructive sleep apnea comes
Uh-huh.
into play. So that puts you at a lot of, that also puts you at a lot of risk. Even in let's say the patient has sleep apnea and you go for, a big hernia repair, that's going to affect you in the recovery phase, right? You're going to have more issues getting extubated. You may have coughing fits. You may have to get re-intubated. So all of this really
Yeah.
comes into play.
Yeah.
So
Very scary.
yeah.
Is it safe to do outpatient bariatric surgery in someone who has a sleep apnea, or is that considered not safe?
We at the moment, I say the majority of bariatric surgeons it's inpatient. So for us, it's about a less than a 24-hour stay. So if
Mm-hmm.
I do, if I do bariatric surgery on a Monday, every patient's going to be going home as long as everything goes according to plan on Tuesday. So they're
Mm-hmm.
there for one night stay. There is some individuals that are starting to look at doing same day surgery for like sleeve gastrectomies, things like that.
Hmm.
So I think maybe over time we would move toward that. I'm not a huge fan of that, to be honest with you. I think the one night, the observation stay, the overnight stay is probably the
Yeah.
safest thing because, like I said, these are, bariatric surgeries become so safe. If you look at just the
Yes.
statistics behind it, weight loss surgery is actually safer than doing a gallbladder removal.
Really?
Yes. Yeah.
Oh,
So bariatric
wow.
surgery has less morbidity and mortality than gallbladders. So it's become really safe. But we still have to remember, and that's because, you have very specific surgeons in centers of
True.
excellence, very
Not
focused.
everyone
This
does
is
those
all we
surgeries.
do,
True.
right? Exactly. So, but we still have to remember that these are really sick, complicated patients. So I'm a fan of, the overnight stay observation is probably for me the way to go. But,
Yeah.
who knows what the future holds?
Okay. Question about the practical difficulties that a surgeon encounters operating on overweight or obese patients. One was there's a lot of torque. Laparoscopically, there's a lot of torque,
Yes.
so it really affects your wrists, your thumbs,
Mhm.
your elbow, your shoulder, your neck, like everything, your upper body and your
Yep,
back is horrible.
exactly.
So much.
Um, yeah, I mean, it is obesity just makes everything more difficult, right? So even if you're doing an open hernia repair, just retracting, seeing the tissues, getting really healthy bites on tissues, all these things, maneuvering the tissues, all this becomes much more difficult. It's not an ideal situation. Even in lap and robotic, the same thing, like the amount of torque, sometimes, just the body habits alone makes like a laparoscopic case maneuverability almost impossible in some situations. I mean, we all,
Mm,
every surgeon always says, oh, it was a really hard abdominal wall, it was large, I bent my instrument, et cetera, things
yes.
like that. Um, Robotically, though, I have to say this is that probably, I use that cutoff of 35, but I kind of been stressing this whole talk about in open cases.
Yes.
I think as now what we're seeing is that the data suggests that we could probably push the BMI cutoff for complex hernia repair in a lap or robotic patient probably closer to 40. And that's because of we mentioned like the wound site
Yeah.
infections, healing processes. When you're having tiny little incisions, it's obviously much easier than when you have a huge incision that goes through your entire abdomen. So there is definitely, significant benefits to the lap and the robotic repairs.
And do you see any like complications related to their obesity just laying on the bed for during the surgery? Do people get decubitus like pressure ulcers or anything like that?
We've gotten pretty good about understanding where all the pressure points are. So we are really diligent about making sure that all the pressure points, like the hips, the ankles, the knees, all this stuff is really
Yeah.
well cushioned during surgery. Because, like I said, even if you're doing like a robotic TAR, I mean, you're probably gonna be in the OR for a few hours. The same thing with like a bypass. They're gonna be on the table for quite some time, for a little bit of
Yeah.
time. So so we try to do our best. We give proper, we try to prevent it as best as possible.
The
Definitely.
next question we pretty much answered. How do you handle emergency hernia surgery in bariatric patients? Do you do anything special? Like if it's open, do you use special like wound protectors or close the skin or a certain way that's
No,
different
honestly, I
or
I try to keep, nothing out of the extraordinary. I try not to, I guess the best answer is don't be a hero in the
yeah,
situation. Try to get in, do your best, make sure, get the patient out of the life-threatening situation that they're in.
yes.
That's the number one key.
That's the key to all emergency surgery. Yeah,
Exactly, right? And then the
yeah,
second thing is then you start thinking about, okay, I want to temporize the hernia or the abdominal wall, the issue that they're having. And then after that, then get them to the point where we could do a great, solid formal repair.
that's great.
Yeah.
Well, we're almost towards the end of our hour. Did that go fast?
How is that an hour? It felt like we
Right?
just exactly.
Yeah, and then we still have more questions, but we did cover those other questions a little bit already, so I think they'll be happy that it was answered. Um, so how do patients find you? Do you see patients outside of Florida or
Anybody who, I mean, if anybody wants to come and visit me in sunny Florida, they're more than certainly take a flight, come on down and visit. But we're in the Tampa, Florida region area. So we are we kind of serve anybody kind of down in the southwest part of Florida, and we get, I mean, I have patients in some situations where they'll drive, 3-4 hours to come and see us. So
Yeah.
that's actually, that's obviously, really kind of them to do that. And it's nice that they put their trust in us. But I think for us, we have a really localized center where we could do the weight loss and the hernia repair kind of all in one spot.
That's
So
very unique.
patients like that. Yeah.
Yeah, most of the time we have to kind of partner up with a bariatric surgeon. It's very
Yeah.
few kind of hybrid surgeons that do bariatrics and hernia as well. You're
I
one
let
of
them
them.
know. I let them know. I said, you're going to be stuck with me probably for a good 2 years of your life. So sorry.
That's
But
great. I'm sure that's very happy. Well, that's the end of it, guys. Thank you everyone for joining us. This finishes yet another wonderful Hernia Talk live session. I enjoy every single one of these, and I'm so appreciative of everyone who joins us every week. We have another great guest next week, getting close to the holidays. So I hope you enjoy that. And thank you, everyone. Remember, this episode and all previous episodes will be on my YouTube channel at Hernia Doc, and also on Facebook. It's currently available. So follow me, subscribe, and we'll see you all next week. And thanks again, Sal. I really appreciate it.
thank you. And thank you for doing this and being a wonderful patient advocate. I think everyone
Thank you.
appreciates it. That's
Appreciate it.
great.
Appreciate it.
course.
Thanks to all you to help me.